All right, I believe we are live.
Great.
Good afternoon, everyone. Another Bariatric Friday. That means today is Friday, Friday the 21st. I'm here with Dr. Isaias Irgau. My name is Kemal Erkan. I'm the chairman of American Surgery Center. This is the bariatric program at American Surgery Center with the partnership with CHRIAS. Dr. Erkan, how are you doing?
Very well, Kemal. First of all, happy birthday, my friend.
So today is one of my birthdays, Dr. Erkan. So there are several other days that we have to celebrate.
I am happy it's happening on Bariatric Friday. I'm very happy to be here today.
So thank you for being with us. So I'm going to actually introduce our other program providers. So I'm a little bit far from my computer. And then when I realized that I'm actually having a little bit difficult time to see the mouse pointer. So hopefully everyone can see what I'm sharing. All right, so the CHRIAS and Surgery Center, American Surgery Center team with Dr. Irgau, Dr. Gail Wynn, Dr. Michael Peters, Dr. Rahul Singh, and Dr. George Ibrahim on the bariatric side, and then Dr. Sachin Vaid on the colorectal surgery side. And we do also have our dietitians, Fran, Beth, Amy, and Amy Scott. And this is a multidisciplinary program with several years of experience in bariatric. And today we are going to discuss another topic. And many of our patients are going through similar issues when they start the process. At some point, they do feel like they're overwhelmed and they drop. And Dr. Irgau, you have done so many of these, and you do see so many of these patients. And today we are going to actually discuss why do they drop? So if you can kind of give us the background on this, and then we can have a discussion on this topic.
Of course. So essentially, morbid obesity, Kemal, as we have said many times on our program, is a disease. It is a very serious disease, and it is accompanied by many other health problems. So when we talk about performing bariatric surgery to help people lose weight and get out of morbid obesity, we're actually offering a very important form of treatment, right? In fact, currently, bariatric surgery really is the most effective treatment we have, for morbid obesity. And this has been demonstrated on studies after studies. So the question, of course, is, why do patients drop out when they start the process, right? But an even bigger question, Kemal, is, why is bariatric surgery being performed on less than 1% of the people who are eligible for bariatric surgery right now, right? In any other area of healthcare or disease, this would not be acceptable at all, right? And yet with bariatric surgery, here it is, right? We are able to reach less than 1% of the people who actually would benefit from this treatment. And that affects also.
Hold on one second. I'm just making sure that my screen is acting up. I just want to make sure that I'm sharing the right screen. So
yeah,
sorry about that.
No problem. So, and it's a problem, as your slide is showing, that it's not getting any less. It's actually growing. In fact, if you look at the map of the United States and you were to color the different states of the United States with different colors to represent different levels of obesity throughout the years. And for instance, if you were to color obesity rates less than 10% with a very light color, and then obesity rates of greater than 30% with a much more dense color, you would see that starting from the 1980s, every decade, almost all states go from a light color to a much denser color, suggesting that obesity rates have grown really from less than 10% in the 80s to as much as 30% or above in some states, right? So when we have this overwhelming problem, we're not able to reach the people who actually would benefit from this treatment, right? And one of the problems, as you know, as we will discuss, of course, is that there is a stigma against obesity, right? Even doctors have been very, very late in recognizing that obesity is a real disease. It's actually relatively recently that the American Medical Association has recognized obesity as a disease. Think about that, Carl, right? So if even the healthcare profession has been so slow really to understand how important it is to tackle obesity as a disease, then society at large, which has been living under this assumption that has stigmatized obesity for so many years, then it's no surprise that most people don't look as treatment of obesity as a legitimate and very important form of treatment.
So I think one of the other issues that I see is the access to care type of challenges. And then I did write an article regarding this several years ago. Even at the surgery center, with our kind of like concierge service approach, we still have people dropping out of the program, and that is related to everything that you just said, and also with the insurance companies discriminating these patients, our patients in these cases. You know, what's interesting is, as much as this is not being recognized or understood by medical professions and also by the society, as we are screening our patients, we do daily case conferences in two different setups, one in the accountable care organization and one in the bariatric setting. In the ACO setting, Dr. Irgau, more than half of the patients do have these problems. So the morbid obesity in a way. So, you know, the interesting is that they have all the other illnesses, and then they're not being addressing the core of the problem. And why? Who knows? When we are trying to actually bring that to the attention of the patient, they're like, oh, we want to see the patient first. Well, you just saw the patient. Let's actually take care of this. But this is a sensitive issue you don't understand. Well, diabetes is not sensitive. So if diabetes is not sensitive, why is obesity sensitive? It's a disease. No disease is sensitive, right? So that actually is one of our problems.
Absolutely. So yeah, absolutely. So when we're talking about dropout, clearly what we're talking about, Kemal, is that a patient comes in, recognize that bariatric surgery is important for them, and they have a consultation with us. And then when we have the consultation, we determine that bariatric surgery is indeed appropriate in their case. And then we enroll them in the bariatric program to prepare them for the surgery, which includes education, it includes evaluation. So once we've started that, some patients do not complete the process. And the question obviously is why, right? Well, let's look at it in a different way. Come on. Let's say, for instance, a patient comes to a doctor because they have been diagnosed, let's say, with a very slow growing type of cancer, right? Let's take, for instance, a type of sarcoma, certain types of sarcoma, which is a cancer of muscle tissue, grow very, very slowly. Or another type of cancer of the intestinal tract is known as carcinoid tumor, and they also grow very, very slowly. In fact, sometimes they're known as slow motion cancers, right? Let's say somebody comes in and you diagnose them with that, and you tell them, okay, you need surgery, you need treatment for that, right? Well, that person immediately will take on the role of the sick person, right? And they will tell their family, they will tell their friends, I have cancer, I am sick, I need treatment. And everybody will rush to them to support them. They say, yes, when are you going to have the treatment? Who is going to be your doctor? When is happening? Why is it not happening soon enough, right? Immediately it's recognized it's a disease. Now, if you go to your friends or your family and say, I suffer from morbid obesity, I need bariatric surgery, how many people will rush to you with the same type of sympathy to support you? Will they let you acquire that role of the sick person who needs desperate treatment? They will not. They will not, right? In fact, most people may not even tell their family or their friends that they're seeking this treatment because of the stigma that we have against obesity. Because we think obesity not as a disease that has been imposed at the person, but as a condition that the person has chosen to acquire. That is our problem. That's where we can get out from, right? People do not choose to become morbidly obese. They become morbidly obese because biologically, that's what's happening to them. Of course, living in a society like ours, it's a perfect setup for that, as it is a perfect setup to develop other illnesses, other types of cancers, right? But we don't judge those other diseases based on the merits of the person. We tell the person, yes, you're sick, you need treatment. But when it comes to obesity, we stop there. So that huge stigma hanging over obesity is a main problem that we have to be able to overcome. People need to understand it's a serious illness that comes with high blood pressure, with diabetes, with sleep apnea, with many other illnesses that cuts short people's lives, that ruins the quality of life of people because of the illnesses that they have. And yet, our approach is different. So the reason I see many people dropping out is because of that stigma, Kemal, right? If we understood firmly that it is a disease, life-threatening disease, like many other medical conditions, we would be seeing a much more different approach to it. So that is what we have to overcome. Well, you talked about insurance companies, Kemal, in putting a lot of obstacles instead of encouraging people to seek treatment. Well, they are running away with such policies because of the stigma of obesity. Nobody is coming out to defend these patients, right? You and I recently were reviewing certain criteria that have just popped up on the insurance company side, right? When, for instance, so we used to know that one of the criteria for eligibility for surgery is having a body mass index greater than 35, right? But if you have one comorbidity like high blood pressure, that used to be the case. Now they're telling us, no, it's not just high blood pressure. It has to be high blood pressure being treated and not controlled, not by one medication, not by two medications, but by three medications. So you have to have high blood pressure that does not respond to three medications before your morbid obesity can be considered for the actual treatment of the condition that is driving the high blood pressure, right? And the insurance company imposes that. There is nothing the patients can do. There is nothing we can do as well. So advocating for our patients and really diffusing the knowledge like you and I were doing right now is very important so that our patients don't drop out.
So the main thing is, Dr. Irgau, when I don't remember how many times I said this in so many different sessions. So when the patient drops today and they come back 6 months later, they're at least 15% heavier than before. Now, unlike me, if you go to your driver's license change and then they ask you what's your weight, and then you said it's the same as it was 20 years ago, never changed. I was 190 pounds 20 years ago, and I'm still 190 pounds, not, but on the driver's license I am. And I'm not 190 pounds, but on the new driver's license I am, right? No one comes back, especially when you are dealing with the weight issues. Now, at a higher BMI level, this is a more severe problem. I personally, and you know this, go through so many patient charts. So today, actually yesterday, I was talking to Dr. Vanising with the bariatric progress. So she's our bariatrician. She's not a surgeon. Actually, we should include her in the introduction.
Absolutely.
So
Absolutely.
she actually, she made a comment of like she was amazed how many patients we were going through in those sessions. But also, one of the things that she said, how we remember all these patient problems, and we have a system in place, number one. Number two, we do go through so many patients, and I told her, I said, well, you can actually just test me right now. I can probably present 10 patients I'll be probably 70% accurate, but I can really present 10 patients easily without any problem because patients are having similar issues, same problems, same challenges. So when they stop and then they come back, that's definitely, they come back with more weight, more BMI, more pounds. So now what we know is everything that these, everything around the patient, including insurance companies, including the state policies, including the public opinion, including our families, including medical society, they're against the patient. So I think that's part of the reason that when I write this access to care challenges and discrimination by the insurance company, so just think about this way. Many of these patients are going through psych issues. They have depression. So now when they are on, when their insurance is Medicaid, you say you have to do 6 consecutive nutrition class. 6 consecutive. It's not like you can do 6 in 3 months. That's not enough. I want to see how you're going to do in 6 months. It has to be consecutive. So you have to prove that you are like a stable person. That's what it's saying. That's a sick mind. Actually, that's like, I'm not trusting you. You don't deserve to get a surgery. But let's see if you can just go through the 6 months. You're going to fail anyway. So then I don't want to actually pay for your surgery. So I just want to see you fail. Why can't just state of Delaware change this policy? That doesn't make any sense. What it is that they need to hear, and who do they need this? Who do they need to hear this from? Because it does not make sense. Well, Blue Cross for the commercial, they don't have this policy. Medicare, even for the elderly, they don't have even authorization policy. They don't ask for prior authorization. But the state of Delaware for the Medicaid patients, they're like, no. Like, you have to be, just show me, let's see if you can do this for 6 months. So it's setting you up for failure. That's wrong. So on top of that, patient is already struggling with a lot of stuff. And we are talking about chronically ill patients. So these are not, these patients are already having issues with mobility. They're having issues day to day. This is affecting their life. And insurance companies need to change their attitude. But one of the reasons that we want to actually, we want to have this discussion today is we can't just really fight, we can win every battle, so we just have sometimes better alternatives. We made it easier at American Surgery Center. So at least our patients don't have, they're not on their own. We are supporting, we put a tremendous amount of support there with a huge team, so they can actually stay with their care coordinator, with their surgeons, and then we'll make sure that we are there with them throughout this process, from the beginning to the surgery, and even after the surgery, we are still there. So all these issues, while we are fighting on their behalf, so they can actually get the most adequate support from us, and then we can deal with this issue together in the meantime. But there are some other reasons, right, Dr. Irgau, other than the insurance discrimination, other than the psych-related issues. Sometimes patients are just scared of the surgery itself.
And that is true. That is true. And there is nothing wrong with that. Obviously, surgery is surgery. Of course, when people hear the word surgery, they are concerned, and that's absolutely legitimate. What we have to work at is to really try to see whether the risks of the surgery are comparable with the risks of the disease itself, right? Now, as we have said many times in these sessions, bariatric surgery has become extremely safe nowadays, right? We have come a long way in making sure that many of the potential complications are actually prevented to begin with. surgeries, right? There are some potentially life-threatening complications that can happen with bariatric surgery, but in very good programs, high quality programs like ours, which are certified as centers of excellence, these complications are very, very rare. And that the reason is because we focus on prevention and we are extremely successful in preventing these complications to the extent that bariatric surgery now, so various forms of bariatric surgery, including gastric sleeve surgery, for instance, are comparable to things like gallbladder surgery or hip replacement surgery in their safety profile. So we have come a long way. But obviously, ultimately, the patients will have to decide themselves because it's their body. And it's our job to inform them about the potential complications. And some people, obviously, may decide to hold off, and that's okay. But as you said correctly, Kemal, in the vast majority of situations, we see the condition worsen over time rather than improve. So if somebody hasn't gone through the surgery now and they come back in a year or 2 years later, they are likely to be heavier, they are likely to be sicker than when they are. And this is not a coincidence. There is a reason for that. And the reason is obesity itself is actually a platform that encourages more obesity. In other words, once you reach a certain level of obesity, right, it is a lot easier to gain more weight than it is to lose weight. A lot easier. So just like, some medications can make you gain more weight, just like lack of sleep can make you gain more weight. Obviously, just like increased calorie intake, lack of exercise can make you gain weight. Obesity itself makes you gain weight. It's a platform that does that, right? So if a person has a weight of 320 pounds, right, and they don't go with the procedure now, and they come back to us 6 months, 12 months, 18 months later, it is likely that their weight is a lot higher. We see that invariably. Patients will not come back to us if their weight is lower. The chance for their weight to be lower by itself is also very low because it's very hard to lose weight effectively without bariatric surgery once you reach certain levels. So holding off doesn't improve the condition, right? So education is what we have to present. So patients being concerned about safety of the surgery is a legitimate concern. It's our job to really present to them what the risks are. The risks are there. There is no surgery without risks. There is no zero risk, of course. But what we have to take them through is that make them understand that the long-term risks of obesity far outweigh the short-term risks of surgery itself. And that's where it is obviously important for us to present the education. And then as far as the other issue you mentioned, Kemal, correctly, which is lengthening the preparation period arbitrarily, which is seen in many insurance companies saying that you have to almost to have the right to passage, to demonstrate to us that you can come to appointments month after month for 6 months before we can authorize your surgery. There is no data to prove that that's actually a good way to prepare patients for success. In fact, what we see is you really increase the failure rate because many patients will not go through the program if you lengthen the time they need to prepare for the surgery. So we have to be able to challenge this to insurance programs, saying that absolutely preparation is necessary, evaluation is necessary, education is necessary, a multidisciplinary approach is necessary, but arbitrarily long periods of waiting time are not only helpful, but actually could be damaging because they are really going against what we're trying to achieve, and that is to get patients to go through bariatric surgery.
Like even for the smaller weight loss goals, unless you see like couple pound losing couple pounds, it's getting motivated and going through that whole thing is difficult. So exactly what you are saying, if we are delaying this process and then saying that, okay, now you have to wait for 6 months, that comes to 7, 8 months with the other stuff. Now the patient is not seeing that the light at the end of the tunnel, and then now they're more depressed, they're more discouraged, and it's just difficult. And providing, so the solution is there. I mean, the level the cutoff is already so high, so that it's not like it's not like the BMI 22 that you are starting, like already at the 35 minimum. So
Yep.
there's no
Absolutely.
going back from that. So it's really difficult to understand. But again, what we did instead of, because changing this is going to take time, but for us to be able to put a really good program in place, because it takes a lot of time and effort for us to be able to get everyone all together every day, go through every patient once a week minimum, and then discuss their upcoming issues, outstanding issues, discuss those with their physicians, their other specialties, helping them with appointments. It's a huge support, and then our patients. That's why our patients are extremely happy, and they are satisfied with what they get from us, and hopefully we can actually help more people in 2022. So that is what we have for today. Dr. Irgau, anything you would like to discuss, you would like to share?
No, Kemal, I think this is an important issue. Again, we're really going to the heart of the problem, which is the stigma of obesity. The misunderstanding of the importance of bariatric surgery has to be, brought out and discussed like we're doing. But obviously, you should be very proud with our program because we have one of the lowest dropout rates in the country, really. When you look at many studies, the dropout rate is a lot higher. And the reason the dropout rate is so on the lower side on our program is because of what you said, of the attention that the program gives to every single patient as they go through the program.
So it's not the number of the total consults, but what we can do with the patient. So the patient is important. So from the time that they get in, we want to make sure that they get the maximum attention from us, so that keeps our retention rate high. So, and yes, we are proud of that. So hopefully we can have more people in 2022. And did you see our new billboard on 95?
Yeah, excellent. I like it. It's wonderful.
Good one. So hopefully our patients can see it too. Dr. Irgau, thank you for joining me, and we'll see you next week.
Yeah.
See you guys soon.
Bye-bye.